With that, I'd like to introduce our keynote speaker for today, who will also serve as moderator for our first panel on the multilateral perspective. And we're very pleased to have with us today Tim Evans. Tim is the Senior Director of Health, Nutrition, and Population at the World Bank Group. He's been really at the forefront of advancing global health equity and strengthening health systems delivery for more than 20 years. I'm sure most of you here already know him. He's been an Assistant Director General at the World Health Organization, Director of Health Equity at the Rockefeller Foundation, and a co-founder of many partnerships, including Gavi, the Vaccine Alliance. So we'd like, Tim, if you would please, give us some of your own insights and thoughts on these transitions.
Thank you very much, John, and good afternoon to all of you. Lots of familiar faces, and I hope I can shed some light on this issue, but really as a means of provoking and starting the conversation, because I don't think 20 minutes will do justice to the complexity of the issues, and I think John, you've laid out the landscape, very nicely. Let me begin by just taking us back a bit to, demographic transition, which is really sort of the basis for thinking about transitions in the context of health. And this is most fundamentally the idea that societies transition from high fertility to low fertility, high mortality to low mortality as they develop and age. And this slide is a messy one, but I put it up deliberately because in the bank I run the health, nutrition, and population global practice, but population cuts across all of development. And this life course view that looks at sort of pre-dividend countries where high fertility and high mortality are still very much the picture, but that transcends into the rights and opportunity for youths and adolescents, the labor market conditions, and finally the conditions for the elderly, is really the heart of development. You have to think fundamentally about people, and I think demographics really brings that scientific assessment of the distribution to which all health systems need to be incredibly sensitive. Now, the idea of transition is that this changes, and this changes quite quickly in some settings. China, for example, is going to have something like 80 million people over the age of 80 by 2030. Most countries don't have 80 million people. They're going to have 80 million over the age of 80, right? Brazil's demographic transition is such that by 2030 they'll have 50% of the population over the age of 65. These are really cataclysmic changes when you think about what it means for social protection and policy and the health sector as well. So just to say that this is such an important fundamental driver of our understanding, and too often neglected when you realize that our basic data points for whole populations are decennial censuses. Totally inadequate at the moment in a digital world, etc. So I like to start there, but it's not just demographic, it's epidemiologic. And how many of you have heard of a guy called Omran? I used to teach, and this is basic stuff. So I'm not surprised at all that Sir George, being the student and professor of global health that he is, gets this. But Omran created this theory of demographic and epidemiologic transition, which is really important because with the change in the aging of the population comes a change in the nature of the health problems that you're dealing with. And this is really important because, as he beautifully, and I think, in a way which still stands the test of time, identified pre, early, late, and post-transition in both epidemiologic and demographic terms and showed that interface, you can see that many countries most countries are beyond pestilence and famine, but many are still in early demographic transition, many also in late, and some in post. And in many countries, it's almost all three at the same time. And so understanding that this interface of population with biology, environment, and health is, I think, really a fundamental part of making sure that what we do to design health systems is sensitive to needs. Transitions. John talked about this. He's been intimately involved. I call this the legacy transition. And so on this front, we have come a long way since 1988 to 2017. Hopefully we're going to be even closer by the end of 2018. Things are looking pretty good. But when you think about a massive apparatus that's been built up over 30 years transitioning, what does it mean? And John knows this much better than me, but I think a couple of things that are worth mentioning. First is the knowledge and know-how that have been built up, especially in the last years. Amazing stuff going on in terms of the efforts to surge around new cases, revaccinate, identify populations, follow them, work in extremely difficult environments, because many of the environments where we are in the end game are difficult environments. That's a knowledge and know-how that we need to secure because it has value elsewhere. It is not specific to polio. Second is the people. We've got thousands of highly skilled polio workers that are internationally employed. And that's perhaps the toughest dimension. Where will those folks go? Because their likelihood of transitioning into national level salaries is low. And it's not clear that international agencies will be able to absorb them all. And when you look at that, a large proportion of them are concentrated in some of WHO's regional offices. And were they to leave, then you have real issues related to the integrity of those institutions, given that it's such a large number. So those are really, really important. Finally, financing. If we get to zero, and let's say we get to 0 cases next year, and then you've got 3 years before you can say eradication, then you've got another 10 years of IPV. And that's a heavy lift, especially when there's 0 cases. And having just come from the Gavi board, where Gavi looks as if they may be inheriting this opportunity to manage the IPV legacy, especially as the replenishment comes up in 2020, one needs to think about how to finance this in a way where this doesn't substitute for other important parts of the Gavi agenda, but is actually additional. And so what ways could you perhaps sell through IFM, polio eradication bonds, and have that done in such a way that the 10-year price tag, which is about $2 billion, gets forward financed and underwritten in much the same way that IFM has advanced financing for many other vaccines. Those things are going to be important. But crucial on this front is not to forget the value of eradication. It is an infinite stream of benefits. And as we deal with finance ministers who have short-term memory deficit, you've got to keep on reminding people that, in fact, there's huge value in making it to that 10-year mark, because you have basically guaranteed humanity an endless stream of benefits, which we will forget if we don't make abundantly clear. Gavi and Global Fund are going to be represented here, and part of the challenge in transition is that countries are getting more mature and growing economically, which is great, but raises questions fundamentally about whether they should be eligible for grant financing as they have received in the past. So when a country becomes middle income, you say, well, can't they afford this on their own? Why should this be on the global public taxpayer's dime? And so there are a lot of discussions going on about, well, what's the appropriate threshold? And there have been many analyses now that show that many middle-income countries have huge at-risk and needy populations in terms of poor vaccine coverage or high rates of HIV, et cetera, et cetera. I put this slide up, which is, this is an indicator that's used in the bank's decisions around how it makes decisions in allocating financing to low-income countries. And it's something called the CPIA, Country Policy Institutional Assessments. And the point of this slide is to say that the calculus for deciding on how to gauge which countries should be eligible for how much concessional financing through our IDA fund is a function of all of these variables. So it's not a single threshold. It's not uniquely that a country reaches $1,200, $1,600 per capita, and then they're cut off. There's a whole set of other things that factor into the equation. And I think one of the things in helping Gavi and Global Fund and others think about that transitional point when they can start to wean more effectively from the best or easiest or most generous form of development assistance is an index that takes into a whole set of factors which you think are going to be perhaps better an indication that a country would be able to sustain not only the financing but the programmatic capability to secure progress moving forward. So I just put that up. It's a little bit of advertising, but a lot of the things that the bank does, which I think are very helpful, aren't well perceived. Because most of the forum I go to, people attack me and say, oh, well, the bank said, Gavi or the Global Fund has to, divest or move away from financing once you reach a certain income per capita threshold. And the bank does develop that data, but it doesn't use that data to make decisions on how it manages its concessional financing. So the other transition that I want to talk about is what I call UHC transitions towards universal health coverage. And this is a function that the aspirations in the 21st century of people everywhere are for that universal entitlement to health. And so this is not a top-down agenda coming from Dr. Tedros in Geneva. I think this is a bottom-up. Aspirations are driving politicians everywhere to provide comprehensive health services. But we've got some important transitions to make in the context of services and financing. And so I'll just make 2 points on this. This is some data from something called the Service Delivery Index, which looks at facility performance. And there's a bunch of countries in Africa on the left. I'm not sure anyone can see it with the back, but it looks at the difference at levels of diagnostic accuracy, adherence to clinical guidelines, and clinical management of maternal and neonatal complications. And you can see all this being lower half that all of these indicators of good quality service delivery have massive room for improvement. And here we've got to really recognize that the systems engineering that's required to get this up into the 80% level and higher is non-trivial. And so that transition is really important because sustaining coverage of financing for sustaining coverage of immunization or basic services, bed nets and good treatment for maternal health is a function of making sure we really not only get to access but good quality service, what Tanahashi Everybody knows Tanahashi, right? Sir George? Oh, I got you. Tanahashi wrote a very famous paper in the Bulletin of the World Health Organization in 1978. You should all read it. It was basically what gets in the way between a very efficacious intervention and its effective delivery on the front lines. So, but we really have to bridge that delivery gap and invest in that transition. On to financing, because I'm at the bank and that's what we're supposed to do best. We've got a lot of room to improve on this front. This is just looking at the problem in finance as we know it today, which is most low and middle income countries are pre-health financing transition, meaning they're financing their systems out of pocket when patients are ill. Most inequitable, most inefficient, yet it remains the principal form of financing. Okay? So, and it mostly affects the poor much worse, or the poor are more adversely affected than the rich, as this slide shows in data from East Asia. But when you look at out-of-pocket financing globally, it's about $500 billion that's spent annually out of pocket. Okay? Mostly in low and middle income countries, and that's growing at 3 to 5% per year. Total development assistance is how much in health? $35 billion. Okay? What's bigger, $500 billion or $35 billion? Okay? If you could get 25% of that $500 billion to be prepaid and pooled, that would be 4 times the value of development assistance. Okay, so there's a huge opportunity to look at how you can move systems towards something that was discovered by Bismarck and Beveridge in the 19th and 20th centuries, but we know won't work. It's not a Beveridge or Bismarckian system, which is the solution for low middle income countries with very high levels of informality and very poor public taxation capability. Even when we put the win-win-win tax, which Sir George asked me to mention, of taxing unhealthy behaviors, cigarettes and alcohol. Those are great things to improve domestic resource mobilization, but we need to really rethink social protection for health in these settings, and this is a critical transition that we need to move on. Last 2 examples. We're trying to do this through something called the Global Financing Facility, where we're looking at what we need to scale financing to eliminate excess maternal and child mortality by 2030. And we have a starting point in 2015. We have an end game. And this line on the bottom is what would happen, what we think will happen, the counterfactual for domestic resource mobilization if nothing is done. And what the lines above it are is how we might improve and strengthen that. The dotted line at the top is smarter financing with existing resources. You can actually decrease the amount of money you need because you are getting better value for money. And we need to think about moving on these axes of smarter, more efficient financing at scale, because you're not going to get there if you're doing 25% of what you need, and make sure that this is a joint public and private domestic enterprise, and redefine ODA such that it's catalytic and contributing to the institutions that are going to do this in the long run. Now, this is financing in peacetime, and the problem is we don't always have peacetime. And this is the Ebola crisis we had in West Africa, where, by the way, we not only had a crisis in the outbreak of the epidemic, we had a crisis in financing because most of the financing, which was huge, came way too late to make any real difference. Okay, so if you don't have contingency financing capability baked into your systems, you stand to lose a huge amount of ground, as these countries did in West Africa. And so on the basis of this, we developed something called the Pandemic Emergency Financing Facility, which is, for the first time ever, creating a private market in pandemic insurance. And a lot of people didn't like this concept at all, except when we talked to several ministers of finance and said, would you like to have a public pool that you put aside every year of $500,000 or $1 million and you keep it there? Or would you like to pay a premium and be able to get that dispersed within 48 hours? And when you ask a minister of finance that, they always prefer the premium because they know how difficult it is to preserve a big visible pool of public finance. There are piranhas everywhere that will be looking to get some share of that. Whereas if they have a premium and it's good value for money, then they purchase that discreetly as part of the budget every year, and then when the rainy day comes, it triggers and they get the cash in seamlessly. So that's the theory. When we issued this in Zurich last year, almost to the day, this was 200% oversubscribed. So clearly there was appetite for this. But perhaps more importantly, in the context of the DRC outbreak that we're in the middle of right now, and I think we're doing relatively well, touch wood, the PEF, through its cash window, dispersed on day 14 of the outbreak, and it covered the shortfall in the $56 million response plan by contributing another $12 million, which is now being deployed by both WHO and UNICEF that were pre-accredited responders through the PEF facility. So we've managed, I think, to move in the right direction with respect to thinking about how we can not only be prepared for the transitions of peacetime, but also the transitions of emergencies, which are incredibly important and will be a defining reality that we have to deal with moving forward. So with that, I'll thank you for your attention and look forward to moderating the discussion. Oh, last thing, sorry. How could I forget? Yeah, I mean, I missed the Stanley Cup here. I was in Geneva at a Gavi board. I was furious. As a Canadian, you know, this is the only thing you live for. But you know, all Caps, the Washington Caps won. But one of my heroes growing up, Wayne Gretzky, I think really said something that we need to pay attention to in thinking about transitions in the future, which is he skates to where the puck is going to be, not where it's been. And I think anticipating where we're headed enhances the likelihood of successful transition and winning Stanley Cups. Thanks.